have any disclosures. So ECMO, or extracorporeal membrane oxygenation, is used to provide respiratory and cardiac support for patients of all ages. I've done most of my work on ECMO, a little bit at Houston Methodist, but most of it has been in children at Seattle Children's. And so essentially what you do is put a large catheter in, blood goes through the venous side, gets pumped through an oxygenator and a heat exchanger to warm it back up, and then back into the patient. There's two forms of ECMO. You can put the blood back in on the arterial side, and then it can provide blood pressure support and perfusion, or you can put it back on the venous side, and then it's primarily just providing respiratory support. So it can be life-saving, but it's associated with high rates of bleeding, both spontaneous and procedural cannula-related bleeding. And another problem is thrombus formation in the circuit, which can lead to arterial embolism if it's on the arterial side, hemolysis, most commonly due to pump thromboembolism, and we'll talk about that. And then you can have various forms of circuit failure requiring them to change out the circuit in the patient. And so there's a repeated need for platelet and red cell transfusion on these patients. Typically in small children, they get a transfusion every day or every other day, typically both red cells and platelets, sometimes also the need for cryoprecipitate as well as plasma. And so really the goals of this presentation was to talk about how pathology, both anatomic and clinical pathology, can play a role in reducing bleeding, understanding better thrombosis that goes on in ECMO. So we'll talk about sort of 4 topics here and hope you have a better understanding at the end. First was optimizing anticoagulation. When blood hits this artificial plastic surface, it activates and that causes thrombus formation. And so at least all the children, because they have lower flow rates through the circuit, are on some kind of anticoagulation, most commonly these days heparin. So we'll talk about therapeutic drug monitoring. And then one of the things that I learned when I was over there is they would decide they were going to change the circuit, and I would say, well, what's wrong with the circuit that you're changing it? And they would say, well, it has a pressure problem, or it doesn't seem to be oxygenating as well, or the patient's just using a lot of blood products, and so sometimes we just change it. But they often really didn't know what was wrong with the circuit. So I actually decided to do a bit of anatomic pathology, and that was when they would change a circuit out or take a patient off ECMO, then we would take the circuit down to the morgue and we would do a little circuit autopsy. We would do an analysis of circuit thrombosis. And so it found all sorts of interesting information, kind of like back to Virchow days where you're doing basically gross pathology. We also took samples out of it, we'll talk about, to look at the structure of the clots. And so that's been a very interesting and useful sort of, and it, valued by my 1 year of anatomic pathology I did. And we also wanted to look at sort of the, you might say, the basic science of ECMO to understand more what happens when blood comes in contact with this artificial surface. And so we used flow cytometry to develop assays related to cellular activation and injury on ECMO, looking primarily at microvesicles. And then lastly, from sort of a transfusion medicine standpoint, we wanted to better understand what were the causes of platelet and red cell loss on ECMO. Why did we have to give these patients a transfusion every day? Not all of them have bleeding, and so there was some other mechanism that was causing them to lose the platelets and red cells. So first, therapeutic drug monitoring, extracorporeal life support started with cardiopulmonary bypass during open heart surgery. With cardiopulmonary bypass, the duration of support is short, several hours, but intense. 100% of blood flow is provided by the circuit, and it requires high-dose heparin to prevent circuit clotting, typically about 10 times the amount of heparin that you would use for a regular ECMO circuit. The activated clotting time is a point-of-care test that's sensitive to high-dose heparin, and it was used to monitor heparin during cardiopulmonary bypass. ECMO was derived from cardiopulmonary bypass, but the duration is longer, typically about a week for patients at children, but can last several weeks to months in a few. The flows are lower, and low-dose heparin, about 0.3 to 0.6 units per mil, is used to prevent circuit clotting while minimizing the risk of bleeding. So first of all, sort of optimizing anticoagulation. When ECMO was created, since it was taken from sort of a cardiopulmonary bypass circuit, the activated clotting time was selected as the test to monitor low-dose heparin levels, but it really wasn't evaluated sort of in a low-dose system. So in discussions with the ECMO group at Seattle Children's, they expressed concern about high levels of circuit clotting using ACT heparin monitoring. This was about 4 years ago. We started a project then to compare ACT-based heparin monitoring with anti-10A heparin activity monitoring for ECMO. And the first thing we did was just basic lab medicine in vitro studies. This is looking at the unfractionated heparin level here versus the activated clotting time. And you can see up to somewhere around 0.6 units per mil, there's really no change in the ACT. So it really wasn't monitoring the heparin at all, at least looking at in vitro studies. And it went up above, it increased when the heparin level got up above about 0.6 units per mil. But considering the fact that most patients are between about 0.2 and 0.4, sort of in this range, it didn't look like the ACT was going to be sensitive enough. This just shows anti-10A sensitivity, and it's very linear, very sensitive, down to about 0.1 unit per mil. So from a laboratory medicine standpoint, it looked like this was insensitive and that the anti-10A would probably be a better test. A flip side is that the ACT is a whole blood clotting time. So we wanted to see what other things it might be sensitive to. And we found that the ACT was sensitive to clotting factor levels. As the factor level increased, the ACT went down. It was also sensitive to contact factor levels. It uses contact activation, like a PTT, to activate the system in an ACT. So it was sensitive to contact factor levels like factor 12. It was also sensitive to platelet count. So platelets provide the phospholipid source in the ACT, whereas the ProTime and the PTT have added phospholipid. And so this meant that as the patient's platelet count went down, the ACT went up. So it was sensitive to multiple other things, but it was insensitive to what they were trying to measure, which was the heparin. So this shows then sort of the overall outcome of that, not too surprising. This shows heparin activity in patients on ECMO versus the activated clotting time, and there was absolutely no correlation between the heparin activity level in anti-10A units and the activated clotting time. And so our conclusion really was that the ACT was not useful for measuring the low-dose heparin that they were using during ECMO. It was useful as a threshold test for cardiopulmonary bypass, but that's only because they were using levels that were way out here in the heparin level. So what we did is we started a QA study around about 2016 at Seattle Children's. They were doing ACT about every hour on the patients, 27 times a day on average. They were doing anti-10As only once per day, drawing about 40 mils of blood, which is quite a bit if you think about it. Some of these patients' blood volume is only about 200 mils plus another 400 mils for the circuit. So they were drawing a significant fraction of the patient's blood volume every day to do all this testing. They were changing the dose of heparin about 11 times a day. It was working pretty well. They were keeping it in the right ACT range, but they were, their circuit change rate was about 0.11 per ECMO day, so that you can see over 5 days, about half of the patients would end up getting a circuit change. And about 69% of them showed bleeding. Well, 2016, we discussed it and decided we would increase the number of activated 10As a day to 4, about 4 a day. And this reduced the number of heparin dose changes as they were looking at this number more now. The number of ACT in range went down, this went up a little bit, but already we got about a halving in the number of circuit changes that we had to do. In 2017, we went to using anti-10A as the primary method for monitoring. The number of ACTs went down to about every 2 hours. We were down to about 3 heparin dose changes a day, and we had dropped down to about 1/5 the number of circuit changes. By 2018, we were doing only 7 ACTs a day, we were doing about 4 anti-10As. And you can see the blood draw had dropped from about 41 a day down to 25 mils a day, which was a significant drop. The number of heparin dose changes used to be 11 a day, now it was only 2 a day. And again, we maintained about the same level so that we were down to only about 0.03 circuit changes, so that actually most patients could go through an ECMO run and never have a circuit change. And even though the heparin dose we were using turned out to be slightly higher, we ended up with less bleeding, and that's because we had less variation in the heparin doses that we're giving. I'll show you an example of that. So circuit changes for thrombosis were reduced from about 0.11 per ECMO day down to about 0.028. At about 0.025 per day times 5 days times about 50 per year is about 21 circuit changes per year. That was about 10,000 per circuit change, so it's not cheap. That was about $210,000 saved in circuit changes a year. And in just reducing the ACT saved about 20,000 a year. So we saved just about $250,000 a year in costs. So the patients are getting fewer circuit changes. There's a little bit of risk each time you change the circuit. They were getting fewer dose changes. The nurses like that for the heparin. And we were saving about $250,000 a year. So this just shows sort of another part of what the outcome of this was. And that is trying to get an initial idea of what's the optimum heparin dose that we should be using. Prior studies, Irby said that if you had over 0.2 unit per mil, they saw fewer circuit changes. Henderson said about 0.25 unit per mil was kind of the threshold, and we got a very similar number. The paper we just got published, we found about 0.25. You can see sort of a classic curve was as we went up with the heparin dose, up to somewhere between about 0.2 and 0.25, well, we got an optimal drop in the number of circuit changes. Higher doses really didn't help. Higher doses just led to more bleeding. So we're shooting now for between about 0.2 and 0.4 units per mil while the patients are on ECMO, and this has reduced our circuit change rate by about 80%. There is another kind of drug you can use. We've used it on a few patients, and that are direct thrombin inhibitors. These are drugs, just like the name indicates, bivalirudin and argatroban. They directly bind to thrombin and inhibit it. Bivalirudin has a short half-life of about 30 minutes, argatroban a little bit longer. They've been using bivalirudin in pediatric ventricular assist devices, becoming kind of the standard of care. We use it in ECMO when we get clotting on heparin, or the patient has heparin-induced thrombocytopenia, or when we have heparin resistance, because there's really a desire for less complex monitoring and dosing than we're required to do with heparin. ACT is really also insensitive to direct thrombin inhibitors, except at high doses like cardiopulmonary bypass. PTT is the most common assay used to monitor direct thrombin inhibitors, but it has issues with a flat response at upper therapeutic and supratherapeutic levels, and problems with discordant results. Eccrine clotting time was a test we actually set up about 30 years ago. Good sensitivity and specificity, but seldom used. Our lab and a number of others have looked at using a plasma-diluted thrombin time. So you basically dilute the sample 1 to 10 in a normal plasma and then do a thrombin time. Easy, fast, good range, small modification of an existing test. Has a good calibration curve, pretty fast, takes about 30 minutes. It's available at Children's 24/7. And we've calibrated the assay with bivalirudin so that we report out the results not in clotting times, but in micrograms per mil. And if it goes higher than about 2, then we just dilute it. So I'm going to switch now from therapeutic drug monitoring to anatomic pathology. And we'll talk about the ECMO circuit autopsy. So we evaluated gross and microscopic thrombi in ECMO circuits after removal, documented the gross location of the thrombus. Then we disassembled the oxygenators to evaluate the extent and depth of thrombus. So we evaluated clot structure using H&E. We also did immunofluorescence for fibrin, von Willebrand factor, and nuclei. And then we did immunochemistry for histochemistry for platelets, monocytes, and tissue factor. So this will give an example of sort of what you could learn clinically from a circuit autopsy. just like the things that we've learned over hundreds of years from doing patient autopsies. So here's an example of a case. It's a patient that we're using our hemoglobin, plasma hemoglobin assay, which is available 24/7. Reference range is less than 22 milligram per deciliter. And you can see that on the first day when we evaluated it, a level of about 60. Most patients have a level of about 50 to 60, so it's elevated, but this is considered acceptable. But then you can see the next day it shot way up to 400, way too much. And so this is a level, something on the order of 20 to 50 times what you'd expect in a healthy patient. And so the next thing to do is really to draw another one and make sure that this wasn't a problem with drawing the sample and hemolyzing it. But the next one showed a similar level, and they waited and drew 1/3 one here. And then at this point they decided, yes, it was real, and then they needed to do a circuit change. So we got the circuit, and when we disassembled it, this is the rotor out of the centrifugal pump in the system. And you can see that there's a big clot in here, and it had wrapped itself around these rotor veins. And then what happens is the rotor gets out of balance. It's spinning at about 3,000 RPM, so it's like a centrifuge that's out of balance, and so it's going around like this. And the effect of that at 3,000 RPM is what's called cavitation. Little bubbles form in the blood, and it basically tears the red cells apart. And so this was the cause of the hemolysis. Once we changed the circuit out, the patient cleared out the excess plasma hemoglobin. And so this just gives an example of where doing the circuit autopsy could tell them the actual cause of why the patient was hemolyzing. And we'll show some examples of where we figured out why these clots were forming. Now here was one of the most interesting findings. Sometimes when the patient's on ECMO, they will see a rapid increase in the delta pressure. Delta pressure is how much pressure you're using to push the blood through the oxygenator. What's the pressure on one side versus the other side of the oxygenator? And it really should be only a few millimeter mercury. Typical might be about 5. But you can see, like on this chart, these are days on ECMO, and this is the delta pressure, that over a series of days it started to go up, and then over about 24 hours it really shot up until the delta pressure was nearly 100. At that much pressure, you will start to cause hemolysis and other problems. The circuit also usually doesn't oxygenate very well if you have to press that hard. So when we dismantled the oxygenator, what you can see is each of the little pores where the blood goes through is full of clot. And it was basically completely occluded with clot. Now what's interesting about this is the clot is only on the surface of the oxygenator. The tubules are about 1 inch thick, but when we sort of took it apart, we could see that this clot is only on the surface. This shows the immunofluorescence. Green is fibrin, red is von Willebrand factor. And what we saw was basically a solid clot that was occluding the surface membrane tubules. It didn't really extend beyond that. We don't understand yet what the mechanism is, but this had never been described before. They would see this phenomenon and they would change the circuit out, but of course then they'd just throw the circuit away. So we've now seen a number of kids that have had this problem, and it can occur very rapidly. One we had recently, it started up and we talk about all these cases over there, and so I'd said, well, if you ever start seeing it go up, you got to watch very carefully. And so they saw one child, the delta pressure went up to about 30, and the attending physician in the ICU said, it's worrisome, let's get another circuit ready. It was only about 3 hours later when it was up to 100, and luckily they had come in, they had the circuit ready, and they swapped them out quickly. We still don't know exactly what the mechanism is. This just shows an example of 5 patients that had this rapid oxygenator thrombosis. A couple of them had thrombosis before going on ECMO, so they had a history of venous thrombosis. One had a lung abscess, another had a viral lung infection. Others have had really fairly significant shock, even though they were on the ECMO. While it can provide some cardiac support, you can see here very low blood pressure. Patients had high levels of lactate, indicating poor perfusion. And so low blood pressure shock and lactic acidosis seems to be maybe another cause. But the ones that seem to be the strongest association is a prior history of thrombosis, a particularly bacterial infection going on, and possibly shock associated with other mechanisms. So we've examined 41 circuits. We saw 5 of these, about 12%. Rapid delta increase to about 100 over 2 to 7 days. and as we've said, prior venous thrombosis shock, difficult cannulation. It's interesting, low heparin was present in one case, but we've had a number of patients where we have to drop the heparin low because they're bleeding, and they don't usually develop this, and we can come back up on the heparin later. So still trying to understand what the mechanism is. Like I said, we're back in Virchow days. We're still describing sort of the gross anatomic pathology and then looking at histology to try to understand what's happening. This shows another significant risk we worry about, and that's arterial tubing clots. On the arterial side of the circuit, of course, the blood's flowing back in, and particularly if we're using venous arterial ECMO, then the risk is if a clot breaks off of this tubing, you can see here's clotting on the tubing surface. If this were to break off and flow downstream, it can go back into the patient and then essentially cause heart attack or stroke or infarction in the kidney, a variety of places. And so we're very careful about watching the arterial side of the circuit. Basically, the nurses go through with a flashlight and look at the tubing. When it's on the patient, of course, this is full of blood, but this fibrin shows up as kind of a white flash in the flashlight. So they can see that, and if it gets too much, then they'll swap out either the circuit or the arterial limb of the circuit. So we took some of these clots out and looked at their structure. This is where the tubing was. We removed the clot because this tubing is so dense that you can't really make a good cut through it with the microtome. But you can see here's where it was attached, and you can see from the bright sort of green fluorescence that the first layer that forms is really fibrin. And then we got layers of red cells and white cells and platelets that form on top. You can see this sort of grayish is really the fibrin here, and then you get sort of an upper layer of red cells. So the first layer forming is fibrin, and that really suggested that it was coag activation, probably contact activation on the surface, thrombin generation, and then formation of a sort of fibrin layer on the plastic. We showed an example of a thromboembolus in a pump rotor. This is another one showing a thromboembolus. And when we started studying these, we're trying to understand, well, why are these kids forming these big clots on the venous side that then break off and go into this? Because, of course, what we want to do is prevent it, in addition to just describing it. And so in a number of cases, we saw these big clots were forming in patients who were getting antifibrinolytic therapy. So, of course, antifibrinolytics are drugs that block the removal of fibrin. They're very useful for preventing bleeding post-operatively. We use them occasionally after cardiopulmonary bypass and open heart surgery if the patient's bleeding. But like I said in the previous slide, it looks like what first happens is fibrin formation, and you get sort of a layer of fibrin forming on these tubes in the ECMO system. And so if you give the patient a drug that blocks fibrin removal, then they just build it up faster and they build clots quicker, et cetera. And then of course the risk is here's a clot in sort of a venous connector, and this clot can break off and then go into the pump and then cause the cavitation in the hemolysis. We also saw unusual clotting, not in these little pores like I showed you before, but this is on the surface of the plastic. So sort of an unusual clot. This was one too. Another thing that's interesting is once they start forming a clot, the blood flow around the corners of the oxygenator isn't quite as good, and so they'll start to form little clots there. And if they're on antifibrinolytic therapy, then these clots can grow and grow. When we dissected this circuit, the clot extended full thickness in the oxygenator out to about this point. It hadn't actually reduced the oxygenator's ability to work, but you can guess as if the clot continued to extend, it would have caused the oxygenator to fail. So risk here is really if you're on antifibrinolytics for more than about 24 to 48 hours, then you're at risk of developing tubing thrombi, and then of course the concern is getting a pump embolus. When patients were on antifibrinolytics, most of them developed significant tubing clots, 75%. 2 of them developed clots that broke off and embolized the pump, and oxygenator thrombosis was seen in 100% of them. You can see otherwise the risk of developing clot is about 1 in 4, and the risk of a thromboembolus is only about 3%. So, you know, there's a 10 to 20-fold increased risk of developing a thromboembolus and hemolysis and circuit change if you're on antifibrinolytics. So it's still very useful to prevent clotting, prevent bleeding, after open heart surgery, but we try to keep them for less than 24 hours, and then that seems to reduce this risk. Another thing we noticed is you could form clot around this metal axle that goes through the middle of the pump, and then this clot stays there until it gets too big, and then it fragments off and goes into the oxygenator, all these little pieces of clot. At first we were worried about this, but then we studied it and found that we couldn't actually see any evidence that it was degrading the oxygenator. And so while it doesn't look good, the pump axle thrombus fragments didn't seem to cause any problems. Interesting though that the companies worked on this because they didn't really like this as something that was coming out of their pumps, and so they developed a magnetically levitated pump rotor, and that pump rotor really doesn't have these metal axles, and it produces almost no axle thrombi. So they've kind of eliminated this problem by altering the way they designed the pump rotor. This just shows sort of the data from these thrombi. They're twisted, tortuous, sort of degraded clot. You can see this is degraded red cell, and this is masses of white cells and platelets, et cetera, and fibrin kind of degrading, twisting, and it gets to a certain size, and then they blow apart and go into the oxygenator. So circuit analysis findings, patients that seem to have a hypercoagulable state like venous thrombosis and infections may be at increased risk of this oxygenator membrane thrombosis. That occurred in about 12% of cases. Tubing thrombi occur in about a quarter of cases, unless it's antifibrinolytic therapy, more than 48 hours, and then it's occurring really probably in 75% of them. The real worry here is the arterial side, because that has the greatest risk of stroke, et cetera. And then lastly, these metal pump axles generate small thrombus fragments, but they're not really associated with oxygenator failure, and with a newer kind of pump oxygenator design, they seem to have eliminated this problem. So useful to study this. We can help explain what's going on. We can give them some suggestions on how to prevent it. And this one we're still studying, try to understand why it happens. So the next thing to understand, look at, was really what happens when blood hits the artificial surface of this plastic and the oxygenator. What happens to the platelets, red cells, et cetera. So this just shows a resting platelet, kind of a diagram of one, and protein on the platelet surface called CD41, and we're just using this platelet protein by flow cytometry to identify either platelets or microvesicles that have come from platelets. So a resting platelet will show CD41 on its surface. It has a neutral surface charge, and it's kind of oval shaped. When the platelet gets activated, it forms stellate processes, and the negative or the neutral charged surface changes to a negatively charged surface due to phosphatidylserine exposure. In a patient, in us, calcium would bind to these negatively charges, and then the coag system would assemble on that calcium. We can evaluate the presence of these negatively charges using a protein called an Annexin-5. And so we're really going to look for CD41 to indicate that something came from a platelet, and an Annexin-5 to indicate it was an activated platelet. And so in addition to forming sort of these stellate processes, at the end of each of these processes, an activated platelet forms this tiny little bleb called a microvesicle, and these things pop off. So this is an active process, and we can look for these in the blood. They're quite small, less than a micron in diameter, and we can look for both CD41 and an Annexin-5 on the surface. So activated platelets will still be CD41 positive. They'll have a negative surface charge, and they'll be sort of spiculated, and they'll release these extracellular vesicles. So this just shows another sort of cartoon of this occurring with these little membrane blebs coming off from an activated cell. They can be evaluated using high-resolution flow cytometry. The Apogee flow cytometer we're using can see things down to about 0.2 to 1 micron. And this just shows size on this axis, and then it shows CD41. Not surprising, as these microvesicles get bigger, they simply show brighter, more CD41. And then this shows the annexin versus CD41, and we see sort of two classes of them. So everything up here is a positive platelet microvesicle, and we see some that are annexin negative, and then we also see this kind of roughly linear increase, more annexin and more CD41. And so we were interested in determining sort of what's the explanation for these two different kinds of microvesicles, the annexin negative ones and the annexin positive ones. So this shows what the flow cytometry of the microvesicles looks like for normal patients, normal plasma. This is annexin down here and CD41. Again, you can see small number of annexin negative microvesicles, and you can see this annexin positive in normal plasma. Some patients, you put them on ECMO and really not much happens. They don't activate the platelets. Here's one ECMO patient, really looking not much different than the normal plasma, and their ECMO pattern, or their microvesicle pattern, really didn't change from before to after starting ECMO. In contrast, look at this patient, very high levels of microvesicles, and it looks like they have a lot of this annexin 5 or annexin positive microvesicles in this patient. So very different response, and these were taken essentially within the first hour of the patient being on. So some patients show almost no response, some a very strong response. So we did some sort of in vitro studies to compare with this. This just shows if you take normal platelets and you add a strong platelet activator called an ionophore, then you get a very strong annexin response. You can see almost all of the response is this annexin positive microvesicles showing this linear. And in the patients, we're seeing a very similar response in some patients. So this suggests that if you see this, you're really seeing a lot of platelet activation. This just shows one case. The patient came in, had a microvesicle level of about 30,000, and then within 15 minutes of going on ECMO, it had shot up to almost 600,000, about a 20-fold increase within 15 minutes. And at the same time, their platelet count went from about 500,000 down to 300. The microvesicles were then cleared as long as with the activated platelets. And so you see sort of a drop in the platelet count and a drop in the microvesicle count, but still quite high. And so what we see in some patients is they rapidly activate their platelets. Those activated platelets are cleared and the patient's platelet count drops dramatically. In other patients, they go on ECMO and they don't really see a substantial drop in the platelet count. They'll see a little bit of dilution going on to the ECMO circuit, but then their platelet counts are quite stable. So there's really quite a difference in way different patients respond. And this suggests that there may be some underlying mechanism, either genetic or something to do with what was going on in the patient before they went on ECMO that would determine sort of their response. Now, the other thing I described were these microvesicles that were annexin negative. And these annexin negative microvesicles, we see those in platelet storage. So if you take a unit of platelets that's outdated in the blood bank, and then you measure sort of the microvesicle level in that, what you see is an increased number of these annexin negative. So it isn't that the platelets are being activated while they're being stored in the blood bank, but instead this seems to be a signal of platelet senescence, that the platelets are aging and then they drop off these annexin negative. So this shows a patient that had massive bleeding and got a massive transfusion, including large numbers of platelets. And you can see that they sort of showed this signal, not so much the platelet activation signal, but a signal similar to this platelet storage lesion. And we think a significant fraction of this is basically just the microvesicles we were infusing along with the platelets. Now, we also looked at red cells, and one thing I learned new in this, I learned a lot of new things, is that red cells can be activated too, not quite in the same way as platelets, but you can activate a red cell with an ionophore and they'll release microvesicles as well. This just shows normal plasma red cell microvesicles. Now we're using CD235 glycophorin to indicate that these microvesicles came from red cells. And then again, we're using annexin. And we see not quite the same pattern, not that nice linear pattern we saw before. Some annexin negative and sort of a broad distribution of annexin positive in normal plasma. And then in some patients on ECMO, we would see what looked like red cell activation. We would see a big cluster of microvesicles here, more annexin positive ones. And then we also saw this completely new group that we never saw really in any of the normal plasmas. We also didn't see it when we added ionophore. And this was a bad prognostic sign. This would slowly develop over a series of days in patients that weren't doing as well. And when we saw this, all of the patients died. Don't know what the mechanism is, really more of a prognostic finding that we're trying to follow up on. So extracellular vesicle studies, ECMO results in activation and damage to platelets and red cells. Some RBC activation patterns were associated with poor prognosis. Platelet and RBC transfusion also transfers platelet and RBC extracellular vesicles. Endothelial extracellular vesicles were also detected. They increase about 5 to 10-fold during ECMO, suggesting endothelial activation and some degree of vascular injury is occurring in some patients. And monocytes release extracellular vesicles that are filled with bilirubin and seem to be associated with the metabolism of hemoglobin that's being released both through intravascular hemolysis and extravascular red cell clearance. The last thing I want to talk about is mechanisms of red cell and platelet consumption. So the things that people had talked about would be pretty obvious. The most obvious cause for red cell and platelet loss on ECMO would simply be bleeding, blood loss. Second would be platelet activation. They would call this circuit DIC, and they would see that the patient's platelet count would go down rapidly, and they would have to keep getting them transfusions, and so they would swap out the circuit. Sometimes this helped, but often after a few days they would see the same phenomenon start again. And then you can get platelet and red cell damage and destruction. So this could be due to pump embolism or a hemolytic reaction or complement activation, et cetera. The typical clinical evaluation of this, of course, was platelet counts and hematocrits 4 times a day, and then looking at transfusion records. And then we have a stat plasma hemoglobin assay, like we said, available so that they could look for hemolysis with this. So this is sort of the standard for how platelet loss and red cell loss was being monitored. So from a research evaluation, we really wanted to get a quantitative estimate of how many platelets and red cells we were losing. And then we also wanted to use the platelet and red cell extracellular vesicle analysis as a measure or an indicator of sort of platelet activation and destruction. So this shows sort of what we did for platelet loss. We come up with a total quantitative platelet loss rate. This is calculated from changes in the platelet count and from platelet and red cell transfusions. And so the platelet loss rate was really equal to kind of the sum over all these different counts we made, change in count plus how many platelets we had transfused into the patient divided by the time between counts. And then we're also normalizing it by the amount of blood in the patient plus ECMO circuit. So with this as an overall measure of how many platelets the patient was losing per day, we were really measuring it in sort of 10 to the 9th platelets per liter per hour. Then this would give us a measure of overall loss. Then we wanted to look to see what quantitative measures of loss could we come up with. Well, of course, we're doing phlebotomy. Remember I said we drew up to 40 milliliters a day originally. Now it's down to about 25. So we could measure how much phlebotomy we did every day, and we can calculate that. And based on the patient's platelet counts, we can determine how many platelets they were losing from phlebotomy. And we could also use the extracellular vesicles to estimate how many platelets were being lost because of platelet activation. Turns out the half-life of the platelet microvesicles is about 6 hours. And so if you measured the level, you could calculate how many platelets were being activated and lost due to platelet activation. So this gave us 2 quantitative measures. And then we started looking to see if this had any relationship to clinical outcome in the patient. Normally, platelet loss would be equal to platelet production, so our platelet count doesn't change, it stays stable. And the rate of that is about 0.36 times 10 to the 9th per liter per hour. We look at platelet loss during ECMO. This is really loss in excess of what you would need to make to just replace normal platelets. And you can see that it's about 9-fold higher on average, but some patients had much higher than that, up to 50-fold higher. We looked at this platelet loss rate, and we kind of looked at 4 groups. Patients that really had no platelet loss, about 5% of patients, like I showed you, you put them on ECMO and essentially nothing happens. Platelets don't activate, they don't lose platelets, they don't get any transfusions. Those patients all had 100% survival, small number. If they showed decreasing loss, if it was higher at the beginning and they were getting better, it went down, good survival. If they had steady loss, also good survival. The worrisome one is if their platelet loss increased while they were on ECMO. That indicated they were doing worse and they had a worse survival. So average phlebotomy was about 34 mils per day, this is an average over multiple years we were studying this. Average platelet count on ECMO about 108,000. Platelet loss due to phlebotomy was about 0.14. It accounted for a 9 plus or minus 17%. So on average, about 9% of platelet loss was due to phlebotomy. Now, if we looked at platelet activation, it's worse the first hour or so on ECMO, a little bit higher during the first 24 hours, and then it sort of settles out. Partly this is just due to the fact that if you have a lot of platelet activation, you end up burning the platelets up and your platelet count goes down. You can see 241, 128, 101. Activated number of So one measure of platelet activation is to look at how many extracellular vesicles we have per platelet. And you can see, again, this tends to be higher early on and then decrease. So we could measure overall platelet loss early on higher, intermediate, and about 1.0. It turned out that platelet activation on average accounted for about 30% of total platelet loss. So we're starting to get a feel for quantitatively what's causing this. We also looked at other measures where it wasn't quantitative but really risk-based. If you had a history of a coagulopathy, consumptive coagulopathy before going on ECMO, so low platelet counts, long pro time, low fibrinogens, then those individuals when they went on ECMO had higher platelet loss. So if you were already losing platelets early, it just made it worse when you went on ECMO. If you had spontaneous bleeding, then you had a not surprisingly higher platelet loss. Procedural bleeding around the cannula really wasn't associated with increased platelet loss. Overall, hemolysis also wasn't associated with increased platelet loss. So platelet loss overall, activation about 9%, or 30%, excuse me. Phlebotomy loss about 9%, which suggests that about 60% of the loss wasn't either activation or phlebotomy, platelet damage, something else going on that we really need to understand further. If you had disseminated intravascular coagulation before going on ECMO, your platelet loss was about twofold higher, and if you had spontaneous bleeding on ECMO, you also had about a twofold higher platelet loss. So this is kind of our current model. We suspect that there's probably genetic influences that relate to this ECMO inflammatory response that determine why some patients maybe activate their platelets and other patients don't. There's also a clear role for whatever your underlying disease was that's driving you toward, if you had a DVT, previous thrombosis, if you had infection, if you had a DIC. And then there are, of course, things that go on during the pump run. If you have issues with the cannula, or they had to turn the pump RPM up, or the flow rate, or the length of duration you were on it. So all of these things can alter it. So if you put all this together, then that gives you sort of the overall blood cellular response. And so really the game now is sort of trying to tease these things out and then figure out which of those we can alter or prevent. We also looked at red cell loss. We looked at total quantitative red cell loss rate from changes in hematocrit and red cell transfusions, analogous to platelet loss I talked about. We can measure the red cell loss from hemolysis in patients that aren't bleeding and that have normal renal function. The plasma half-life of plasma hemoglobin is about 2 hours, and so by looking at the hemoglobin measurements, we can determine how many red cells were lost through hemolysis. Again, we can determine red cell loss from phlebotomy. Normal red cell loss is about 0.14 milliliters of red cells per liter of blood per hour. The loss on ECMO, much higher, on average about 2.7. And again, we saw this survival. If you had low red cell loss, less than 1, survival about 88%, moderate red cell loss about 68%, and high red cell loss 43%. So high red cell loss and transfusion was associated with poor survival. If you had no bleeding reported, red cell loss rate of about 1.6, any kind of bleeding reported about 3.6, so about double. So the estimated red cell loss due to bleeding on average was about 2 milliliters per liter per hour. And then this shows kind of the overall. Hemolysis accounts for about 22% of red cell loss on ECMO. Phlebotomy, surprisingly, about a quarter. So about 1 in every 4 units of red cells we were giving the patient is because we were pulling them out to do lab tests. That meant that about half, about 55% of the red cell loss wasn't hemolysis, wasn't bleeding. These are non-bleeding patients. And it wasn't phlebotomy. So that suggests that extravascular clearance by the liver and spleen is accounting for about half. So looking again back at the microvesicles, we noted that the ECMO patients had about a 7 to 11-fold increase, suggesting that what we're seeing is sublethal red cell injury and activation, and that these injured red cells are probably then being cleared by the liver and spleen. So, sort of summary, anticoagulation monitoring, we really eliminated the ACT for the most part, replacing it with anti-10A. That reduced both bleeding and circuit thrombosis. Analysis of the circuits can determine the cause of circuit failure and hemolysis and platelet loss in some patients. And it gives us a suggestion of things we need to look at further, like this surface membrane clotting phenomenon. RBC and platelet loss quantitation can aid in determining the cause of the red cell platelet loss and the need for circuit change. We're looking more at this to see what can we do to reduce this further. And then RBC and platelet extracellular vesicles are potentially a future measure of red cell and platelet activation and damage. So I just want to thank all those that helped me with this research. Quincy Lamb is my research technologist, and Cristina Figueroa Villalba is a research fellow. And then Nabiha Saifi is one of our transfusion medicine faculty at Children. Jenna Khan was a fellow, a resident here. And then research testing services has been very important helping us all this. The core lab saves me lots of leftover samples. And boy, I have just had a whole series of great med tech students that have developed these assays and helped evaluate it. I also want to thank nursing, particularly Larissa Yalan, who was the ECMO sort of nurse manager, and she has been a great help. I've learned a lot from her about ECMO, and then all the nurses who collected samples for us. And I'd also like to thank Tom Brogan from the ICU, and in cardiothoracic surgery, Mike McMullen and Christopher Burke. Happy to answer any questions.
Was there a reduction in blood use after instituting anti-10A testing?
We didn't see a decrease in transfusion use. We saw a very small decrease in the number of patients that reported bleeding, or that we reported, having significant bleeding, but the transfusion rates didn't go down, they stayed the same. It turned out we were actually giving the patient slightly higher doses of heparin because often the patients were subtherapeutic when we looked at their anti-10A compared to their ACT. So they got a little bit more heparin, it was more stable, transfusion stayed the same, but thrombosis went down.
Okay, Dr. Hamilton Singh asks, do you think that these findings are generalizable to adult patients or specific to PEDS patients?
Some of them might be generalizable to adults. Adults are different, and I didn't really put slides in here about that, but if you think about it, the major difference in adult versus children, particularly like neonates, is that an adult has 5 or 6 liters of blood in their body, and the ECMO circuit volume is about 500 milliliters. So there's about 10 times as much blood in the patient as there is in the circuit. And the circuit has very high blood flow through it, so it's being sort of swept out. On the other hand, if you look at the neonates, like one of them we were just looking at the other day, a premature infant, their blood volume was about 200 milliliters, and the circuit volume, even with the reduced circuit, was about 400 milliliters. So most of the blood is in the circuit and only a little bit's in the patient. So this patient is trying to metabolize all of these activation products. and they're getting at least 20 times as much activation product going back into them as an adult is, relatively speaking. When I was at Methodist, it wasn't uncommon that we could actually run the adults who had good high flows through their ECMO circuit without any anticoagulation, or with really low dose. So some of these things probably are occurring in adults, but I don't know that they occur as often as they do in really small children and neonates. And since neonates are the most common patient we're treating at children, we're really seeing a kind of a different model where they're seeing more activation, lower flows through the circuit, and probably have more risk from it.
Dr. Nestor asks, regarding the association of worse prognosis with increased platelet need on ECMO, are the patients dying of intracranial hemorrhage? Is there a correlation with the reason/diagnosis that placed them on ECMO?
So the first part of the question was, in the patients that had poor prognosis and had high platelet usage, were they dying of intracranial hemorrhage? And the answer was really no. Only one of them had died of it in the one series we had looked at. We've been doing pretty good with intracranial hemorrhage. Were they dying of bleeding? That would be just in general, whatever the cause. No, it was usually that whatever the underlying cause of them going on ECMO was, that it was so severe that even though we were able to maintain them for a few days on ECMO, that they essentially went downhill. And I think it was the fact that what we were seeing at the end was that they typically go into shock, start becoming shocky and lactic acidosis and other things, even though they're on the ECMO. So that there's a number of kids. The survival rate on ECMO is about 50%, and there's a fair number of them where you put them on ECMO and you're doing the best you can, but then you realize that either from a congenital abnormality or the underlying process that brought them on, that we really can't stop that process. ECMO is a stopgap to keep you alive for a week while they fix whatever's going on. If you can't fix what's going on, then I think as you drift into that, you get into increased platelet and red cell usage towards the end as the patient's dying.
Okay, David Chu asks, has there been any improvements in the tubing materials and pump designs to reduce clotting, for example, in the tubing and pumps?
Yes, over the years there have. I don't know that there's been any, well, I shouldn't, so I can tell you a little bit about, the question was about improving tubing design, improving pump design. So just since I've been doing it, like I said, they've changed the pump. They now have magnetically levitated rotors that don't have these axles in them. The other thing is, what about the tubing? It turns out it was much worse in the past. Over the last 20 years, they've realized that basically native plastic is very activating. And so what do? Well, some of the circuits we've used have been heparin coated. So the whole circuit is coated with heparin, bonded to the circuit itself. And another thing they've done, which is quite clever, is they've tried to make the plastic look like a normal cell membrane. So they coat the entire circuit with phosphatidylcholine, which is a neutrally charged lipid. And so they try to coat it to make it look like a cell surface. Both of those things reduce the amount of circuit clotting, so it's certainly less than it was in the past, but it's still not enough to fool Mother Nature.
Okay. One more question on here from Mark Wenner. Implication of using ACT versus 10A in other settings, shorter cardiac procedures, etc.
For cardiac, if they're looking at like open heart surgery, the doses of heparin are so high that the ACT works okay as a threshold method to indicate that you've given them a really big dose of heparin. And they don't actually monitor the heparin as much as just show that you've gotten past a certain dosage rate. We haven't really tried to explore the use of anti-10As in cardiac surgery, probably because we're too slow. Even as fast as we are in the lab, they can get an ACT quickly and say the patient's got enough heparin. The real issue comes, and I've had discussions with cardiology and other groups where they're using ACT to try to measure low-dose heparin. I think anywhere they're using it for low-dose heparin, then they really need to evaluate that carefully. Because if they're having problems, it could be that it's not really an accurate measure of low-dose heparin. And what we saw was that it was essentially random. The doses of heparin they would get would be changed 12 times a day, and it would go from 100 to 0 to 50 to 40 as they were basically tracking random ACTs. And then once we got them onto the anti-10As, we would do maybe only 2 tests a day, and often those tests didn't show much variation once we got them stable. So I think we need to look at ACT anywhere it's being used for low-dose heparin.
Okay, and there's one more that Mike Astian asked. Can you talk about the unique way you got this work funded?
Yes, good question, Dr. Astian. So at Seattle Children's, there's a foundation that brings in donations, and once a year they have a big grant called the Funding Hope Award, and that's to try to fund new things that might help children. And so, gosh, about 4 years ago or something now, we got a grant, really 2 pieces. We said we would like to do this ECMO research that we thought could help improve ECMO. And then we also were doing part where we were going to use genomics to do a better job of evaluating patients with cancer. And so we've had significant success on both sides. And then the other way that we've gotten funding is that Dr. Astian had set up a guild, they're called, a small foundation just for laboratory research. And then, patients, staff, whoever can donate to the guild. And so one year we collected money, and that was also used for the ECMO research. He collects something on the order of $50,000 a year from the guild activities. So that was also very useful. And so it's really, a great thing that both the hospital provides money to do this kind of research, as well as the guild that Dr. Astian had set up.
Wonderful. I think that is all the questions.
Thank you very much.